At the hematology ward, there's Braden, a 5-year-old male who developed prolonged bleeding after circumcision. His mother is worried because he has a history of recurrent hemarthrosis after minor falls. Family history reveals a relative of his mother who suffered from bleeding diathesis. Now there's also a 3-day-old preterm baby called Harlow, who is bleeding severely from the umbilicus. Her mother states that she did not get the standard care after delivery. CBC, PT, and PTT are ordered for both patients. They both have normal platelet count. Now Braden has normal PT but elevated PTT, while Harlow has both PT and PTT elevated. Both Braden and Harlow are suffering from a hemostasis disorder. Hemostasis disorders, also known as bleeding disorders, can be broadly divided into 3 groups. The first includes problems with primary hemostasis, which is formation of the platelet plug, so they are also called platelet disorders. The second group includes problems with secondary hemostasis, which is making a strong fibrin clot through activation of the intrinsic, extrinsic, and common coagulation pathways, and so they're known as coagulation disorders. And the last group includes disorders that affect both primary and secondary hemostasis and are known as mixed platelet and coagulation disorders. Let's focus on coagulation disorders that are usually due to a decrease in the number of clotting factors, and causes include hemophilia and vitamin K deficiency. So let's look at hemophilia first. They are a group of inherited bleeding disorders caused by deficiencies in various coagulation factors. Hemophilia A and B are X-linked recessive disorders, so they almost exclusively affect males, while females are carriers. A big hint for hemophilia is a family history of a maternal relative with a bleeding disorder. Hemophilia A causes a deficiency in factor VIII, while hemophilia B leads to a deficiency in factor IX. Hemophilia C, on the other hand, is an autosomal recessive disorder, meaning it can affect both males and females, leading to a deficiency in factor XI. Alright, on to another coagulation disorder, vitamin K deficiency. Vitamin K acts as a cofactor to an enzyme found in the liver called gamma-glutamyl carboxylase, which converts the non-functional forms of coagulation factors 2, 7, 9, and 10 into their functional forms. So without vitamin K, the loss of factor 7 means that the extrinsic pathway won't function, and without factor 9, the intrinsic pathway won't function. And without factor 10 and 2, the common pathway won't function. So all the pathways in the coagulation cascade are affected in vitamin K deficiency. Normally, vitamin K comes from the diet, like in leafy, dark green vegetables like spinach, kale, and chard, or can be made by intestinal microbial flora. So it's easy to see that vitamin K deficiency can occur in malabsorption syndromes like cystic fibrosis and celiac disease, or with prolonged use of broad-spectrum antibiotics that kill intestinal microbial flora such as fluoroquinolones and cephalosporins. Now, deficiency is rare in adults, but neonates are particularly susceptible because breast milk is low in vitamin K, and at the same time, their intestinal flora is still unable to produce it. That's why every newborn gets an intramuscular injection of vitamin K. Whatever the cause, coagulation problems share some common symptoms. People with these disorders can get large bruises after very minor trauma, and this is called easy bruising. They also suffer from ecchymosis, which is discoloration caused by bleeding under the skin, hemarthrosis, which is bleeding inside the joint space, deep tissue hematomas, posterior epistaxis, which causes a severe nosebleed, GI bleeding, urinary bleeding, and persistent bleeding after surgical procedures. Now, a dangerous complication is intracerebral hemorrhage, or bleeding into the brain, which can cause a stroke or increased intracranial pressure. For hemophilia A, B, and C, the symptoms are nearly clinically identical, which makes sense since factors 8A, 9A, and 11A work together in the coagulation cascade to activate factor 10. The severity of the symptoms depends on the severity of the underlying mutation. Having 5 to 40% of normal factor activity is mild, 1 to 5% is moderate, and less than 1% is severe. Unfortunately, most hemophiliacs have severe disease. Male infants often develop excessive bleeding from circumcision or from dental procedures. They can also develop a cephalohematoma, which is bleeding under the scalp due to trauma from the delivery. There's also an increased risk of getting hemarthrosis once they start walking and falling. Repeated episodes of hemarthrosis can cause the joint to deform, severely restricting range of motion and causing chronic pain. Now, bleeding in vitamin K deficiency can be mild or severe and basically can occur at any site. An important fact to remember for the exams is that babies with vitamin K deficiency, especially if they're preterm, can develop a condition known as hemorrhagic disease of the newborn. This usually occurs during the first days of life and is characterized by bleeding from the skin and mucous membranes, the umbilicus, GI bleeding, or intracranial bleeding. Alright, now let's switch gears and look at diagnostic tests. People with hemophilia often have a prolonged partial thromboplastin time, or PTT, since factors 8, 9, and 11 are part of the intrinsic pathway. They will have a normal prothrombin time, or PT, and platelet count. It's important to also rule out von Willebrand disease in these patients, as it too may exhibit a prolonged PTT since von Willebrand factor carries factor 8. Once von Willebrand disease has been ruled out, a mixing study is done to differentiate whether this PTT prolongation is because of true factor deficiency or because of presence of a factor inhibitor, like an antibody. The patient's plasma is mixed with normal plasma that contains all the factors, and then the PTT is checked again. If the PTT normalizes, then the patient must have a factor deficiency and is diagnosed with hemophilia. If the PTT doesn't normalize, then there must be a factor inhibitor involved. In vitamin K deficiency, both PTT and PT are elevated since vitamin K-dependent factors are involved in both intrinsic and extrinsic pathways. PT usually elevates first, since factor 7, which is part of the extrinsic pathway, has the shortest half-life. Now, if PTT and PT correct in response to giving vitamin K, the diagnosis can be confirmed. Now, treatment includes concentrates of the missing clotting factor 8, 9, and 11 for hemophilias A, B, and C, respectively. Desmopressin is also used in hemophilia A, as it stimulates the release of von Willebrand factor from endothelial cells. In individuals with vitamin K deficiency, vitamin K is administered. Okay, to review. Coagulation or secondary hemostasis disorders can occur when there's a decrease in the number of clotting factors, like in hemophilia A, B, and C, where there's deficiency of factor 8, 9, and 11, respectively, and in vitamin K deficiency, where factors 2, 7, 9, and 10 cannot be converted to their functional forms. Now, hemophilia is an inherited disorder, while vitamin K deficiency can occur when there are malabsorption syndromes, prolonged use of antibiotics, and in neonates. A diagnosis can be made based on clinical presentation, patient's history, CBC, PT, PTT, as well as specific lab tests such as a mixing study. Treatment of hemophilias includes concentrates of the missing clotting factor, plus desmopressin for hemophilia A, and vitamin K in deficient individuals. Now back to the patients. Both patients have a bleeding disorder and most probably a coagulation disorder, since PT or PTT are affected and platelet count is normal. Due to his sex, history of recurrent hemarthrosis, family history of a bleeding disorder, and prolonged PTT, Braden probably has hemophilia. A mixing study must be done to distinguish a true factor deficiency from the presence of a factor inhibitor. If hemophilia is confirmed, specific factor 8, 9, and 11 levels will be measured to determine the missing factor. Meanwhile, Harlow, due to her age and prolonged PT and PTT, probably has hemorrhagic disease of the newborn. This makes sense because she did not receive vitamin K after birth.
The word hemophilia is a combination of the Greek words for blood and love, a way of saying that people with hemophilia love to bleed, or rather that it's hard to stop bleeding. This is because the process called hemostasis, literally meaning to stop the flow of blood, is impaired. Normally, after a cut and damage to the endothelium, or the inner lining of blood vessel walls, there's an immediate vasoconstriction or narrowing of the blood vessel, which limits the amount of blood flow. After that, some platelets adhere to the damaged vessel wall and become activated, and then recruit additional platelets to form a plug. The formation of the platelet plug is called primary hemostasis. After that, the coagulation cascade is activated. First off, in the blood there's a set of clotting factors, most of which are proteins synthesized by the liver. And usually these are inactive and just floating around in the blood. The coagulation cascade starts when one of these proteins gets proteolytically cleaved. This active protein then proteolytically cleaves and activates the next clotting factor, and so on. This cascade has a huge degree of amplification and takes only a few minutes from injury to clot formation. The final step is activation of the protein fibrinogen to fibrin, which deposits and polymerizes to form a mesh around the platelets. So these steps leading up to fibrin reinforcement of the platelet plug make up the process called secondary hemostasis and results in a hard clot at the site of the injury. In most cases of hemophilia, there's a decrease in the amount or function of one or more clotting factors, which makes secondary hemostasis less effective and allows more bleeding to happen. Now, that coagulation cascade can get started in two ways. The first way is called the extrinsic pathway, which starts when tissue factor gets exposed by the injury of the endothelium. Tissue factor turns inactive factor 7 into activated factor 7A, A for active. And then tissue factor goes on to bind the newly formed factor 7A to form a complex that turns factor 10 into active factor 10A. Factor 10A with factor 5A as a cofactor turns factor 2, which is also called prothrombin, into factor 2A, also called thrombin. Thrombin then turns factor 1 or fibrinogen, which is soluble, into factor 1A or fibrin, which is insoluble and precipitates out of the blood at the site of the injury. Thrombin also turns factor 13 into factor 13A, which cross-links with fibrin to form a stable clot. The second way is called the intrinsic pathway, and it starts when platelets near the blood vessel injury activate factor 12 into factor 12A, which then activates factor 11 to factor 11A, which then activates factor 9 to factor 9A, and factor 9A along with factor 8A work together to activate factor 10 to factor 10A. And from that point it follows the same fate as before. So both the extrinsic and intrinsic pathways basically converge on a single final path called the common pathway. Believe it or not, this is a somewhat simplified version of the coagulation cascade, but it has all the key parts needed to understand hemophilia. Now, an insufficient concentration or decreased activity of any coagulation factor can cause hemophilia, except factor 12 deficiency, which is asymptomatic. Hemophilia usually refers to inherited deficiencies of coagulation factors, which can be either quantitative or qualitative. By far, the most common of these are deficiencies of factor 8, which gives rise to factor 8A and is stabilized by another factor called von Willebrand factor. And this deficiency is called hemophilia A, or classic hemophilia. Another common deficiency is deficiency of factor 9, called hemophilia B, which used to be called Christmas disease, named after the patient who had it, not the holiday. Now, a mimic of hemophilia A is von Willebrand disease, which is an inherited problem with primary hemostasis caused by a deficiency of von Willebrand factor. So in severe von Willebrand deficiency, factor 8 gets broken down faster and can become deficient too. As opposed to inherited forms of hemophilia, one acquired cause of hemophilia is liver failure, since the liver synthesizes factors 1, 2, 5, 7, 8, 9, 10, 11, and 13. Also, vitamin K deficiency can cause hemophilia, since vitamin K is needed by the liver to synthesize and release factors 2, 7, 9, and 10. Another cause is autoimmunity against a clotting factor. And finally, there's disseminated intravascular coagulation, which consumes coagulation factors. Now, the mutated genes in hemophilia A are called F8, and in hemophilia B, they're called F9. And these are both on the X chromosome, meaning both conditions are X-linked recessive. So it usually affects men, since they only have one X chromosome, and therefore only one copy of the F8 and F9 genes. Women with one mutated gene copy have a remaining healthy copy, so they don't get hemophilia unless X chromosome inactivation turns off the normal copy in the majority of cells. But generally, women are carriers, while men are symptomatic with the disease. Signs and symptoms of hemophilia A and B are nearly clinically identical, which makes sense since factors 8A and 9A work together in the coagulation cascade to activate factor 10. Both of these can cause easy bruising, or ecchymosis, as well as hematomas, which are collections of blood outside the blood vessels that are often deep in the muscles, prolonged bleeding after a cut or surgical procedure, for example circumcision, oozing after tooth extractions, gastrointestinal bleeding, hematuria, which is blood in the urine, severe nosebleeds, and hemarthrosis, or bleeding into joint spaces. A dangerous complication is bleeding into the brain, which can cause a stroke or increased intracranial pressure. Now, the severity of the symptoms depends on the severity of the underlying mutation, which determines the activity of the factor. Diagnosis of hemophilia A and B usually starts with lab tests, including a platelet count, which is usually normal, a prothrombin time, and a partial thromboplastin time. The prothrombin time tests extrinsic and common pathways, which means factors 7, 10, 5, 2, which is prothrombin, and 1, which is fibrinogen. Whereas the partial thromboplastin time tests the intrinsic and common pathways, meaning factors 12, 11, 9, 8, 10, 5, 2, and 1. Since factors 8 and 9 are part of the intrinsic pathway, prothrombin time is normal, and partial thromboplastin time is prolonged in hemophilia A and B. In order to confirm hemophilia A or B, tests to look at specific factor activities and mutation testing of the genes encoding them can be done. Treatment for hemophilia A and B is usually done with injections of the missing or non-functional clotting factor. Unfortunately, if the patient has severe deficiency, where intrinsic production of the factor is absent or very low, these supplemental factors can be seen as foreign by the immune system, which results in the production of antibodies that try to eliminate the injected clotting factors, which are called inhibitors. Inhibitors diminish the treatment's effectiveness over time, and can also sometimes cause anaphylaxis, which is a severe allergic reaction. For hemophilia A, desmopressin, also called DDAVP, is helpful for patients with mild quantitative factor 8 deficiency. Desmopressin stimulates von Willebrand factor release from endothelial cells, which promotes the stabilization of the residual factor 8. Finally, it's best for individuals with hemophilia to avoid contact sports and medicines that promote bleeding, like aspirin. All right, as a quick recap, hemophilia is a bleeding disorder that's caused by an impaired coagulation cascade. Hemophilia A is caused by mutations in the genes for factor VIII, and B is caused by mutations in the genes for factor IX. And these two are the most common genetic hemophilias, and are both treated by supplementing the missing clotting factor.